Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about fungal infections. Definition: these disorders result from infection of the skin by fungal organisms collectively called dermatophytes. Phyte is the Greek word for plant. Various clinical lesions can result, but the most common are scaling, erythematous papules, plaques, and patches, which often have a serpiginous or worm-like border. The word tinea, Latin for worm, is used for these superficial fungal infections. It is followed by a qualifying term that denotes the location of the infection on the body. For example, Tinea capitis is a fungal infection of the scalp, and Tinea Pedis is a dermatophyte infection of the feet. Tinea versicolor is the only exception. Its name derives from the several shades of color that lesions may have in this disease. Synonyms for fungal infection of the skin include dermatophytosis, tinea, and ringworm. Incidence: dermatophytic infections are highly prevalent with an estimated global incidence affecting 20 to 25% of the population. Local incidence rates in clinical settings range from 13 to 23%, depending on population and methodology. The burden remains substantial, with demographic, occupational, and environmental factors influencing incidence patterns. History: in most dermatophytic infections, the patient presents with a scaling rash. Pruritus is common and often the chief complaint. A history of exposure to infected persons or other mammals like dogs, cats, and cattle may be elicited. Physical examination: the physical findings and differential diagnosis vary with different teneas. Tinea Corporis. Tinea Corporis is the classic ringworm. Often patients have a history of exposure to an infected animal such as pet, dog, or cat. Physical examination: the typical lesion is annular with an elevated scaling border and a tendency for central clearing. One or several lesions may be present. In patients predisposed to chronic infection, the eruption may be widespread and not all the lesions may be annular. In this instance, the finding of elevated serpiginous borders in some of the lesions is a helpful clue. Tinea corporis, red scaling patches with serpiginous borders. In epidermis is thickened and stratum corneum infiltrated with fungal hyphae, and in dermis inflammation can be seen. Differential diagnosis: the coin-shaped lesions of nammular eczema are usually multiple and located on the extremities. They are often mistaken by the patient and sometimes by the physician as ringworm. In nammular eczema, one usually sees no central clearing and the potassium hydroxide preparation is negative. Pityriasis rosea starts with a single hilar patch which is frequently mistaken for tinea. The correct diagnosis usually becomes evident when the generalized eruption develops within a few weeks. Although occasionally annular lesions or psoriasis are usually thicker and more scaly than those of fungal infections, more typical lesions of psoriasis are also usually found, and of course the potassium hydroxide examination is negative. Uncommonly, impetigo presents in an annular configuration. The finding of vesicles, pustules, and cruris in annular lesions should lead one to suspect a bacterial rather than fungal cause. Erythema annular, centrifugum, and granuloma annular are two uncommon diseases that may be confused with ringworm. Clinically, the differences are that in erythema annular centrifugum, the scale is inside the elevated border and the potassium hydroxide preparation is negative. In granuloma annular, the border is more indurated and is not scaling. A skin biopsy is helpful in confirming the diagnosis of these two disorders. Both conditions are idiopathic and are usually localized but occasionally generalized. The generalized form of erythema annular centrifugum is called erythema geratum repens, a rare condition that is almost always associated with an internal malignant disease. Generalized granuloma annular is sometimes associated with diabetes mellitus. The conclusion of differential diagnosis of Tinea corporis include nammular eczema, pityriasis rosea, psoriasis, impetigo, erythema annular centrifugum, and granuloma annular. Key points: annular patch with clear center and scaling serpiginous border. Scrape the border scales for the potassium hydroxide preparation. Tinea Corporis, a groin rash, has several common causes. Dermatophytic infection is one. Patients with Tinea Corporis or jock itch frequently also have Tinea Pedis or athlete's foot. The perspiration that occurs with exercise is probably the most common predisposing denomination in these athletic rashes. Physical examination. Dermatophytic infection in the groin may not appear as an annular lesion, but the border is elevated, serpiginous, and scaling. Often lesions have a tendency for central clearing. The scrotum and penis are seldom involved. Tinea Corporis is sharply marginated oval red groin patches, note typical sparing of the penis and scrotum. Differential diagnosis. In addition to dermatophytic infection, there are two other common causes of a groin rash. Candidiasis appears as a bright, intensely erythematous, beefy red eruption with purely defined borders and satellite papules and pustules. The scrotum is often affected. Intertrigo represents simple irritant dermatitis, most often found in obese patients in whom moisture accumulates between skin folds in the inguinal area or other body folds, and along with friction causes skin irritation. The eruption is not as red as that of candidiasis and not as sharp demarcated as Tinea Corporis. The potassium hydroxide preparation is positive in Tinea Corporis and candidiasis but negative in intertrigo. On occasion, intertrigo can be complicated by a candidial infection. Less often, psoriasis and seborrheic dermatitis selectively affect the groin. Erythrasma is an uncommon disease of intertriginous skin caused by Corynebacterium mimetismum. Clinically, it appears as a velvety patch with fine scale that under whose light examination fluoresces the agnostic coral pink. The conclusion of differential diagnosis of Tinea Corporis include candidiasis, intertrigo, psoriasis, seborrheic dermatitis, and erythrasma. Three major causes of a groin rash is Tinea Corporis, candidiasis, and intertrigo. Tinea facial. This is an uncommon but often missed fungal infection of the skin. Physical examination. Tinea facial appears as an erythematous, usually a asymmetric eruption on the face. An annular pattern is frequently not evident, but usually at least some of the borders are well demarcated and are often serpiginous, providing a clue to the fungal origin. Pustules may be present and may further obscure the clinical diagnosis. Tinea facial, oval, sharply demarcated, red and hypopigmented, a whitish patch with a slightly scaling, inflammatory border and cleared center. Differential diagnosis. The lesions in seborrheic dermatitis are usually symmetric and are not well demarcated. Rashes resulting from sunlight or so-called photodermatitis are distinguished by their distribution, which is usually symmetric, sparing areas that are relatively protected from the sun, such as the eyelids and under the chin. Contact dermatitis may also be confused with tinea facial. Occasionally, tinea facial can appear as a butterfly rash resembling that of lupus erythematosus. The finding of sharp serpiginous borders should heighten the suspicion of a fungal origin. However, for any of these conditions, if there is a scale and any doubt, scrap it. The conclusion of differential diagnosis of tinea facial includes seborrheic dermatitis, photodermatitis, contact dermatitis, and lupus erythematosus. Laboratory tests. The single most important laboratory test for all of these fungal infections is the potassium hydroxide preparation. The finding of hyphae on a potassium hydroxide preparation is diagnostic of a dermatophytic infection, whereas a candidial infection will have hyphae and oval layers on microscopic examination. Usually the clinical presentation distinguishes between the two, with candida having a satellite pustules around a beefy red patch and tinea having an annular scaling patch with a clear center. If desired, one can also obtain scales for fungal culture. Cultures distinguish between candidial and dermatophytic infections and are sometimes helpful in patients in whom dermatophytic infections are suspected, but the potassium hydroxide examination is negative. A skin biopsy is not indicated. If a biopsy is done to rule out the disorders, the dermatopathologist may miss the fungal elements in the stratum corneum. Contrary to some misconceptions, a woods light or black light is no help in diagnosing dermatophytic infection of the skin. A woods light fluoresces infected scalp hairs in one type of Tinea Corporis, but infected skin does not show fluorescence. Tinea positive potassium hydroxide examination showing hyphae. Tinea Manuum, dermatophytic infection of the palm, is uncommon but not rare. It virtually always occurs in a patient who has coexisting Tinea Pedis. Physical examination, typically Tinea Manuum, involves only one hand, resulting in the one-hand-two-feet syndrome. It appears as a diffuse scaling of the palmar surface, much like the plantar scaling type of Tinea Pedis. The border on the wrist side is often sharply demarcated. Tinea Manuum, diffuse scaling faint pink patch of only one hand in a patient with Tinea Pedis, the one-hand-two-feet syndrome. Differential diagnosis, chronic contact dermatitis and dry skin or xerosis can also appear as chronic scaling of the palms. However, these conditions usually involve both palms and the border is generally not well demarcated. Psoriasis can affect the palms with sharply demarcated scaling papules. Usually these plaques are bilateral and are more elevated and inflamed than in Tinea Manuum. Often lesions of psoriasis elsewhere on the body support the diagnosis. Potassium hydroxide preparation is necessary in cases of doubt. Tinea Pedis, the feet are most often involved with dermatophytic infection. Tinea Pedis affects approximately 4% of the general population and occurs in three forms, each of which has a different appearance. Physical examination, interdigital Tinea Pedis appears as a macerated scaling process between the toes. It is most common in patients with sweaty feet. Diffuse plantar scaling is extremely common in older patients. It's usually asymptomatic. The skin of the feet appears dry with diffuse scaling of the soles extending onto the sides of the feet. The border may or may not be sharply demarcated. The distribution of this process on the feet has been linked to a mucosa. Often patients have accompanying nail involvement. The vesiculopostural form is the least common type of Tinea Pedis and the one that is most often misdiagnosed. Vesicles and pustules on the instep of the feet should lead to suspicion of this type of Tinea Pedis. A potassium hydroxide preparation of the roof of the vesicle or pustule reveals fungal hyphae. Tinea Pedis, diffuse plantar scaling, paint pink and hypopigmented patch which extends onto the side of the foot and is usually associated with onychomycosis. Acute vesiculopostural form. Differential diagnosis, patients with sweaty feet or hyperhidrosis may develop maceration between the toes simply as a result of retained moisture in these occluded areas. This then provides a good culture medium for the fungus to become secondarily involved. Clinically simple maceration may be indistinguishable from interdigital Tinea Pedis. A potassium hydroxide preparation enables one to diagnose fungal infection, but in both situations, measures to decrease sweating are also important. Diffuse plantar scaling is most often passed off as dry skin. Contact dermatitis and dyshidrotic eczema are the two diseases most often confused with the vesiculopostural type of Tinea Pedis. In contact dermatitis and dyshidrotic eczema, however, the vesicles are usually smaller and rarely progress to pustule. Pustular psoriasis of the palms and soles is an uncommon disease that can also be confused with vesiculopostural Tinea Pedis. If doubt exists, a potassium hydroxide preparation should be performed. The conclusion of differential diagnosis of Tinea Pedis include maceration, xerosis, contact dermatitis, dyshidrotic eczema, and pustular psoriasis. Therapy for dermatophyte infections involving limited areas, we recommend one of the over-the-counter creams which include clotrimazole, meconazole, and terbinafine. The patient is instructed to apply the topical antifungal to the infected area until the skin is clinically clear, and then to apply it for 1 to 2 weeks longer in the hope of preventing recurrence. Note: dermatophytes are unresponsive to nystatin. Chronic Tinea Pedis is notoriously refractory to curative therapy, particularly when the patient has nail involvement. For suppressive therapy, an antifungal powder such as miconazole powder should be used daily on an indefinite basis after the skin has been clinically clear. For patients with a disease that is either widespread or resistant to topical measures, systemic therapy is indicated. Systemic treatment is also most effective for treating scalp and nail infections. Oral systemic agents include grizofulvin, itraconazole, fluconazole, and terbinafine. For dermatophytic infection, grizofulvin was the standard treatment. Adult patients are treated with either microsized grizofulvin 500 mg twice daily or ultra microsized grizofulvin 250 mg twice daily for 4 to 6 weeks. The newer systemic antifungals, however, can achieve better results with shorter courses of treatment and fewer side effects. For example, most dermatophyte infections of the skin can be treated with a 1 to 2 week course of terbinafine 250 mg daily. Doses for children are adjusted downward according to body weight. Treatment of Tinea Corporis requires 4 to 8 weeks of systemic therapy. Adjunctive twice weekly use of dandruff shampoo containing selenium sulfide can shorten the time course of this infection. The conclusion of therapy for dermatophyte infections. Initial therapy for limited skin disease include azoles like miconazole 2% or clotrimazole 1% cream, gel, spray or powder BID. Allylamines like terbinafine 1% cream or gel daily. Alternative therapy for scalp, nails, or extensive skin involvements include grizofulvin like microsized 20 mg per kg daily, 250 mg twice a day, and terbinafine if the patient weight is below 20 kg, 62.5 mg daily. If the patient weight is between 20 to 40 kg, 125 mg daily, and if the patient weight is more than 40 kg, 250 mg daily. Course and complications. Some acute dermatophytic infections resolve spontaneously even in these patients. However, the time course can be shortened by the use of the therapy mentioned above. Complications are where secondary bacterial infections are uncommon, recognizing that fungal infections can produce pustules, particularly when hair follicles are affected. One must be cautioned about misdiagnosing such pustules as being bacterial in origin. Potassium hydroxide examination and culture clarify the matter if one is in doubt. Intertriginous Tinea Pedis can allow bacteria to gain access to deeper tissues. This is a common portal of entry in patients with recurrent cellulitis of the lower extremities, so treatment of the dermatophyte infection can prevent subsequent episodes of cellulitis. Pathogenesis. The three genera of dermatophytes are Trichophyton, Microsporum, and Epidermophyton. Some of these organisms grow only on human hosts, so-called anthropophilic, whereas others can also exist in soil, or so-called geophilic, or on animals, or so-called zoophilic. All the dermatophytes are keratinophilic. Example, they feed on keratin. They all produce keratinases and necessary requirement for their keratinophilia. Stratum corneum, hair, and nail are attractive substrates for these fungi, not only because of the keratin composition, but perhaps also because of their low density of bacterial inhibitors and competitors. Dermatophytes from hyphae through which nourishment is obtained from the keratin-rich host environment. The clinical appearance and behavior of a fungal infection of the skin depend partly on the host response. Slow-growing dermatophytes infecting only the outermost layer of the stratum corneum may not elicit an inflammatory response. The diffuse plantar scaling type of Tinea Pedis is an example. The clinical reaction may also be influenced by the type of dermatophyte. Some are more likely than others to elicit an inflammatory reaction. In general, zoophilic dermatophytes provoke more inflammation than anthrophilic ones. Tinea Corporis from Microsporum canis, Latin for canine or relating to the dog, is an example of an infection from a zoophilic dermatophyte that produces an inflammatory red scaling annular lesion. Human dermatophytic infections may resolve spontaneously, probably as a result of cellular immune responses provoked by antigenic material from the organisms. Persistent infections occur in patients who do not mount this immune reaction either because the fungus has failed to provoke it. Example in chronic Tinea Pedis, in which the fungus growth remains superficial in the thick stratum corneum and does not gain access to the circulation, or because of dermatophyte-specific host immune deficiency. Dermatophytic infections do not invade beyond the epidermis because of their dependence on keratin for nutrition and the fungistatic properties of the transferrin and beta globulin in human serum. Okay, this was an explanation about fungal infections. Thank you for your attention.